Okay, now we move to chapter 18. We have had our baby. We are now in the postpartum period. Let's look at postpartum issues. We're initially going to look at postpartum physiologic changes, and we're going to look at the reproductive tract, the urinary tract, the GI tract, and psychosocial issues. First, the reproductive tract. There's probably no time in a woman's life when there is such major changes in her physiology than in the delivery to the postpartum period. One of the main ones we are concerned with is the uterus. And we're looking at the return of the uterus to the non-pregnant state. The lining of the endometrium has to be shed, the decidua. And the shedding of the decidua from the uterus is named lochia. I have many students who say, well, the patient isn't bleeding very much after delivery. Well, she shouldn't be bleeding at all. The discharge that you see is called lochia. It initially is reddish color, dark red. We call that lochia rubra. Up to the second week, it becomes more pinkish, and we call this lochia serosa. And after the second week, we call it, it's more of a whitish discharge, lochia alba. And that would be worth knowing for the exam. Lochia rubra, lochia serosa, lochia alba. Now, where does lochia come from? Lochia comes from the lining of the uterus other than where the placenta was attached. So it is the superficial layers of the decidua which are being shed. One of the concerns about the uterus in the postpartum period is bleeding. And now we're looking at bright red bleeding. The physiology of bright red bleeding is bleeding from the open venous placental sinuses. When you consider that 20% of the mom's cardiac output prior to delivery goes through the placenta, that's a huge amount of blood. And if you haven't seen a postpartum hemorrhage, you ain't seen a hemorrhage. One of the physiologic changes that takes place is as the placenta separates, uterus contracts down to keep these sinuses from bleeding. This, in red, is where the bleeding comes from the site of placental implantation. And it's important for the uterus to be contracted. Now here's a good board question. A 26-year-old gravid of 3, now para 3. And I want you to notice she is a multipara. She's had many babies. She complains of lower abdominal pain 6 hours after spontaneous vaginal delivery. What's going on? What do you do about it? What she is experiencing is the contractions after birth. And many multiparas say that the after pains are more painful than the contractions of labor. So, anything that needs to be done? No. Conservative management, this is just uterine contractions, and just adequate pain medication orally is all you need to do. This should be midline, it should be suprapubic, it should be below the umbilicus. That's where the uterus should be postpartum. Perineal pain, lacerations, episiotomy. What do you do for that? Well, if you're a sports person and you're injured, what's the first thing you do? Get the ice pack. And that's what we do here as well. On the perineum, we put an ice pack. For the first 24 hours, it is to decrease the inflammatory response, the swelling, the edema. Once 24 hours is gone, there's probably little help, little value to having ice. At that point, a heat lamp can help to mobilize the fluid and to remove the edema. All right, then we move to the urinary tract. The urinary tract is closely related to the reproductive tract. In fact, the bladder is attached to the anterior surface of the uterus. After delivery, we want to make sure that the bladder empties adequately. What do we call the volume of urine in the bladder after the patient has tried to empty all she can? We call that the residual volume. If we checked your residual volume after you emptied as much as you can, and assuming that you're normal, how much should we expect in the bladder? probably about 50, 60 milliliters. Let's give the patient postpartum a little extra room. Let's say she should have up to 2 to 250 milliliters. But what if she has 800 milliliters? What if she has 1,000? Excessive postpartum residual volume. In that case, we want to help augment the contractions of the detrusor muscle of the bladder, and the detrusor muscle of the bladder is contracted by the cholinergic fibers. So we want to use a cholinergic agent. Bethanechol is an example of that. The trade name is urocholine. On the exam, of course, they'll want to have the generic name. What if the bethanechol, the cholinergic agents, don't work? In that case, sometimes we have to send the patient home with an indwelling Foley catheter for a few days. This often occurs if a patient has had an epidural anesthetic. The epidural anesthetic has knocked out the sympathetic fibers which supply the pelvis, and the patient's bladder may be denervated pharmacologically. Give it a few days and she should respond. She just had a baby. The last word she wants to hear is catheter. Urocholine, bethanechol. When nature won't, why, urocholine will. And so that can be very helpful. The GI tract. The main concerns regarding the GI tract have to do with hemorrhoids. 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 Very common post-delivery. Now, almost all women are going to have constipation. They do prior to delivery, they will after. Oral hydration, stool softeners. The hemorrhoids particularly are a problem if there's been a prolonged second stage and mom has been pushing and pushing. You imagine if you had a bowel movement for 3 hours. Pushing, 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 trying to get it out. You'd probably have hemorrhoids too. Management, oral hydration, stool softeners, sitz bath. Sitz bath is basically immersing the perineum in warm, soothing water 2 to 3 times a day. And over time, as the venous pressure decreases, the hemorrhoids will get better as well. Psychosocial problems. Here's a case, postpartum day 1. A patient just underwent a spontaneous vaginal delivery of a 1,900 gram, 31-week baby who had to go to the intensive care nursery. You come around to make rounds in the morning, and you ask the patient, how are you doing? She says, fine. And you say, what's your baby's name? And she says, I don't know. Is that a normal response? Normal response of a mom is to say the baby's name with a smile on her face. My baby's name is Maria. When you see no interest in the baby, particularly where the baby's been taken away from an intensive care nursery, you need to be concerned about impaired maternal bonding. And this is something which can lead to failure to thrive and other problems in the neonatal period. The risk factors for impaired mother-infant bonding: decreased neonatal contact, premature baby, baby who has congenital anomalies, baby who was with low APGAR scores, perhaps distressed in labor, all of those. Now, if you would take that baby away quickly, and let's say that we're dealing with veterinary medicine, a cow or a horse, if you take the newborn away immediately, even if you bring it back after a couple hours, the parent will have nothing to do with it. Now, the human organism is more resilient than that, fortunately, but still, it is important, and our intensive care nursery people recognize this, that even if they're going to take the baby away, they'll take the baby over to the mom. Would you like to hold the baby? Would you like to touch the baby? Even for a few brief moments. And at our hospital, the parents of all babies in the intensive care nursery are social service clients. Patients who have decreased social support are at greater risk as well. Have you seen this woman before? Andrea Yates, Houston, killed her children. Here's another woman, cuts off the arms of her baby. What's going on here? Postpartum depression, postpartum psychosis. Let's look at this. Interestingly, they become roommates in a Dallas jail. Postpartum blues, postpartum depression, postpartum psychosis. You may very well have exam questions on this. Briefly, what do you need to know? Postpartum blues, prevalence, 50, 60, 70%. A lot of women will have this. Now, when we send women home, within 24 hours, often you don't even see this. It's not till they get home that they will develop. But this is typically a positive lipstick sign. The patient takes care of herself, she does her hair, she takes care of her needs, she takes care of the baby. But she's crying, she says, I don't know how to take care of my baby. This may be a physician. I don't know what to call my baby. How do you manage this? Outpatient, conservative management, social support. You're going to do fine. Give a call. That usually is all that's needed. No medication. Postpartum depression, different story. This is a negative lipstick sign. This patient does not take care of herself. She doesn't even want to get out of bed. She just wants to lay there. She doesn't hurt her child, but she neglects her child, just as she neglects herself. This probably is more common than we realize and is underdiagnosed. This is outpatient treatment. Psychotherapy may be helpful, antidepressants. In fact, women who experience postpartum depression previously had depression prior to the pregnancy at all. So that's a risk factor. Now, postpartum psychosis is rare. And I might say the recurrence rate for all of these is very high. If a woman previously had postpartum blues, she may have it again. If she had postpartum depression from a previous pregnancy, she may very well have it again. And postpartum psychoses also. The key difference here is women with postpartum psychoses have lost touch with reality. They hear voices that aren't there. They see things which aren't there. Now, Andrea Yates heard God telling her to kill her children. This is postpartum psychosis. This is inpatient treatment, antipsychotics, and psychotherapy. Do you separate the mother and the child? That's a controversial issue. Many places see a more rapid recovery if under supervision, the mom and the baby can be together. And that's the end of postpartum physiologic changes.